David Goldberg is our guest. He is the president and CEO of Mon Health and the vice president of Vandalia Health. David, good morning. Thank you so much for joining us.
Good morning, gentlemen. Thanks for the opportunity to join you.
I'm not sure if you heard any of the Delegate Mike Hornby segment we just did previously, in which we partially addressed certificate of need, and there are a lot of angles on certificate of need. The biggest one, of course, is from the hospital perspective, and that's why you join us this morning. David, what do you know about the progress right now in Charleston for the partial repeal or full repeal of certificate of need as it applies to healthcare in West Virginia, and your thoughts on what should take place?
So, one, thanks again for allowing me to be with you. So I'm actually driving to Charleston today. There's a House committee later this afternoon to discuss with various parties and perspectives on certificate of need. And while I'm a West Virginian by choice. I've been here. I'm a graduate of WVU. I've been back in the state nearly 7 years. I've worked in certificate of need and non-certificate of need states. I worked in Pennsylvania. I worked in Texas. I worked in Virginia, and now I'm here. And there's pluses and negatives absolutely related to health planning. When I was in Virginia, a very, very strong certificate of need state, the planning that came about to make sure that services are distributed where the populations are and that we don't have too much in one place that takes away from another part of the state is important. States like Virginia are 60% commercial insurance, 40% governmental, or what we would call Medicare, the Medicaids. Here in West Virginia, we're 75% governmental, meaning most of our majority of our people are on Medicare, Medicaid, or the public insurance program of the state. That leaves a very small amount that's commercial. Most of what we see in Medicare and Medicaid reimburses below cost. So your hospitals are working very hard to provide excellent services, quality services, service-friendly service, and make sure that we have access for the people around West Virginia and all the different areas, from the small areas like Webster County to the more populous areas like where you're at, or Morgantown or Charleston.
So if certificate of need is repealed as it applies to hospitals, various different carve-outs are being discussed. Whether any of those actually take place, we don't know just yet. But if certificate of need is repealed as it applies to hospitals, what are your options after that? And how much more dependent will you be on the 20% who are not government insurance?
Well, we rely heavily on some of that non-governmental reimbursement as it is. But I think most people in the state don't realize, I'm not a doctor, but Dr. David Goldberg, go with me on my illustration. As a private practitioner, I can open up a clinic anywhere I want. That is not prohibited under certificate of need as it is today. The legislature has worked over the last 6 to 10 years to modernize certificate of need. As medicines have changed, the ways we do procedures have changed, and technology has changed to treat our patients, so have the laws and regulations, as we would expect. 2 years ago, as an example, the legislature approved a bill that allows hospitals to be able to add services on their hospital campus without getting a certificate of need, and raise the limit from what was then a $5 or $6 million cap, then you go to the state for approval, to more than $100 million. So what does that mean? Using Mon Health Medical Center, if I wanted to open up a brand new bed tower on my campus to put more beds, or if I wanted to open up expanded surgical services that stay within the cap on my campus, I don't need approval. That's huge. We're seeing that across our state today. Charleston Area Medical Center, one of our Vandalia facilities, is adding a rehabilitation hospital in Charleston. We're opening up a neuroscience institute in Charleston. WVU Medicine announced a $500 million cancer hospital over the next few years on their campus. We know Marshall Health and a host of other hospitals have added capital, including the Roan Generals of the world and the Boones. So your hospitals are expanding radiology services, surgical services, hospital-based services to meet the needs of our dynamics in our state.
John?
Can a hospital open up a radiology center 25 miles from their hospital location without a certificate of need?
No. Most of those rules are related to hospital-based services, but you can have radiology services on your campus. So the provision of that modernization also allowed a distance on your hospital campus to be able to add services. And most of our hospitals today have radiology services. There was a law 2 years ago that if you have a certain population in your practice with multiple providers, and I think it was an orthopedic practice in the Eastern Panhandle, they're allowed to offer MRI services in their service. That same approach was taken years back with CAT scanning. So we've expanded access for radiology, lab, and a host of others across the state. And I always say there's a process. If organizations want to expand access and be in the state, apply for a certificate of need. While you're covering the Eastern Panhandle on this radio show and I'm in Morgantown, for those who don't know, Mon Health Medical Center is literally across the street from Ruby, and we compete effectively. We offer services. I don't do transplant. They do transplant. There's no reason to have two right across the street from each other. But both our hospitals offer open heart surgery and do it very well. So competition is alive in the state, access is alive in the state, and we collaborate within the state to make sure that we have a good plan to be able to bring healthcare resources where we need and to make sure people have access.
So under current law, if I'm a doctor, I've graduated, I got all the certificates that I need, whatever that's required, can I open a private practice without a certificate of need?
Yes.
Okay.
And I'll give a great example, MedExpress. Many of us know about the MedExpress urgent cares. That was started by private people. They expanded MedExpress around the state. And most recently, an example is a for-profit company partnered with UPMC out of Pittsburgh. They bought many of those urgent care locations in parts of Ohio, Virginia, and West Virginia, and they have MedExpress. So you have organizations that are expanding care and access right now, based on the laws and regulations of certificate of need already. And to your point a moment ago, I used an example in front of the Joint Health Committee last week. Dr. John Manchin, very, very prominent doctor in Marion County, has been operating for decades. He's a private doctor, has multiple locations. He didn't have to apply to expand. So anyone can do that today.
So I'm a refugee of Northern Virginia. Been a few years now. But where I lived in Fairfax, there was Inova, and then there was Kaiser, and they were everywhere. So under you said Virginia has a very strong certificate of need. I was with Kaiser and Kaiser Health Facilities. So every time one of those new facilities opened up, that required the certificate of need service for them, because they're not all on the same campus. They're all over creation.
Correct.
David Goldberg, our guest here on the program from Mon Health and Vandalia. There's a point that was made in our comment section on Facebook where we live stream the show as well as live to TV10. If Mon General wanted to come to the Eastern Panhandle, you couldn't do it without certificate of need, though, correct?
Yeah, that is correct. We would need to. No differently, if I want to employ a doctor today or open a clinic, I apply from a certificate of need perspective. So that is true, but there's a process. And I'll give a great example. A few years back, Fairmont General in Marion County was closing. The for-profit wasn't able to maintain services there. We applied to build a hospital called a small format hospital in Marion County. WVU Medicine applied to build a hospital. They eventually took over that campus. Neither one of us opposed each other. It was the right thing for Marion County, and now they have two facilities that are providing care for Marion County, southern Monongalia County, northern Harrison County, and we're seeing very, very viable enterprises. So this kind of discussion that there isn't competition in the state for healthcare, there's a lot of competition, but it's planned. I lived in Northern Virginia. I worked at Inova Health System for a while. I ran their children's hospital in Fairfax. I worked at Loudoun Hospital in Mount Vernon. So we have great common roots together. And yes, I worked the certificate of need process there, and we were able to expand services access. Your analogy about Kaiser Permanente being at Inova, opening up their own facilities, working at the Virginia Hospital Center, and proliferating their footprint in Maryland. All of these areas I just mentioned are certificate of need, and there's a process, and your example was a good one. They expanded services, they expanded access, and they compete against a lot of different providers. So the program does work.
Matt Harvey.
Hey, good morning, David. How are you?
Hey, sir. Good to hear your voice.
Yes, sir. Can you, for the people that aren't familiar with Vandalia and Mon Health, can you just quickly describe your hospital system?
Sure. So thanks. Many people realize, first of all, back in 2022, Mon Health System, which comprised 4 hospitals in north central West Virginia, merged with Charleston Area Medical Center Health System, which comprised Kanawha County and Taze Valley at the time in Putnam County. And we came together to create Vandalia. And since then, a year ago, the Davis Health System in Elkins, Broadus Hospital in Philippi, and Webster Hospital in Webster Springs joined us. So we grew to 14 owned and operated hospitals. We acquired the Greenbrier Valley Medical Center from CHS, a for-profit, as well as Plateau Medical Center in Oak Hill, and then 70% of the Charleston Surgical Hospital in Charleston. And then we managed 3 additional hospitals, Grafton City Hospital in Taylor County, Highland Clarksburg Hospital in Clarksburg area of Harrison County, and we have a clinical affiliation with Minnie Hamilton near Glenville State. So we're 17 owned and managed hospitals, 200 plus locations, operate in 5 states with clinics in Virginia, Ohio, Maryland, Pennsylvania, and here in Virginia. We're now the second largest non-governmental employer in the state, have about 13,000 employees, and 2,000 to 2,500 providers operating out of all of our facilities across the Vandalia footprint.
Do you, based on that large network and system, do you have some areas or some facilities that are more profitable than others?
Yeah,
well,
as a system.
Yeah, and I'm sorry. Let me just kind of. Obviously, that's you're going to have more. But the point of that question was, does certificate of need help protect your organization to expand into rural areas based on the protection it offers?
So I think certificate of need does a lot of different things. One, it helps us plan utilization and access. And I know in the Eastern Panhandle, there's a lot of conversations of, do we have enough for a growing population? And I could talk about that after I answer your question. But yes, we do have some hospitals that are profitable, Mon Health Medical Center, Charleston Area Medical Center in particular, our Preston Memorial, which is a critical access hospital in Preston County, generate more revenue over expense. But then we take those dollars and are able to support the hospitals that struggle a little bit more, like our Webster Springs Hospital in Webster County, or hospitals like Stonewall Jackson Memorial Hospital in Lewis County that have lower populations, lower utilization, and we're able to reduce cost because of our scale now. We buy things cheaper in volume. We're able to bring the dollars in and then invest in hiring doctors, bringing in equipment and medicines and technologies to help areas that may not have a broader population to generate enough revenue to sustain themselves.
And I'll switch gears real quick. We talked about PEI, Medicare, Medicaid. It wasn't that long ago that PEI reimbursables were half of Medicaid. Is that have they improved those?
Yeah, last year, the legislature approved, I think it's to go to 110% of Medicare reimbursement for inpatient. There was always decent outpatient reimbursement, but the cost and the reimbursement for PEIA was significantly lower than cost, and the legislature fixed it last year. And I know there's a lot of conversations in Charleston, rightfully so, about how do we maintain the viability and the affordability of health care coverage for our state employees, which deserve it, but also how do we make sure we could afford to pay the premiums. I think all of us know we as Vandalia are what are called self-employed. We insure and provide health insurance for all of our employees, and we pay out of our revenue over expense the dollars it costs to cover someone's health insurance. We have an 80-20 split, like most organizations, meaning the organization pays 80% of the coverage, and the individual pays about 20%. And that's the same, I know, that was put in place for PEIA. But sickness costs dollars, and we need to make sure that we can provide for people, get them on the road to health, wellness, and access. But it does mean that sometimes health insurance can be pricey.
The surrounding states, I know you talked about Virginia, but do the other surrounding states have certificate of need?
Maryland, Ohio, Virginia, Kentucky have certificate in need. Pennsylvania does not. And what I said to the Joint Committee was, working in Pennsylvania, I worked at Highmark's Allegheny Health Network. They have a very strong Department of Health in the state, which helps plan and approve certain projects and expansion. Now, hospitals can expand cancer centers and hospitals, but you need to coordinate nicely with the Department of Health to make sure that there's balance. The other states I mentioned all have certificate in need, and when we hear about the backyard brawl, which I'm a WVU graduate and I don't want to lose to Pitt anymore,
Me
my
either.
analogy here is allow us the opportunity to play fairly and competitively against those other states. If we tear down the walls where others are building walls and we have to field teams, let us be fair and equitable. If I can't go into Virginia to compete effectively, but they can come into us, or Ohio or Kentucky, what does that say about fair and equitable, balanced competition? It doesn't.
As a patient, doesn't that benefit me, though, to have that level of competition?
You get competition today. Your health systems, whether they're independent hospitals, private doctors, employed by health systems or other organizations, are competing today. As I mentioned, you have 2 hospitals right in Marion County, 2 across the street in Monongalia County. In Kanawha County, Charleston, you have the Thomas Health System competing with Charleston Area Medical Center. So there is competition. No one's saying that there shouldn't be, but we have to be balanced in how. Healthcare is not a free market. We're mandated what we get paid by insurance companies and CMS, which is Medicare, Medicaid. We have requirements to see people, which we should do no matter what. But there are those requirements on us. It's not like an open industry like the car business. No one forces me to buy a car. But in healthcare, what I pay and what I get reimbursed is mandated with tons of regulations around me to operate a hospital, a clinic, an ambulatory surgery center, or nursing home.
But if I'm Behemoth Medical Center in Virginia, and West Virginia does away with certificate of need, I'm going to see all of that too. The benefit of me encroaching on the contested territory isn't there. So I think the fear of being overrun doesn't make sense to me, because it works both ways. The new competition coming in isn't going to be attractive.
I think you'll have pockets where that will happen, and some of the more populous, commercial payer rich areas are going to see significant growth and repetitiveness in some services, which takes margin and revenue away from the existing facilities that may be investing in other communities that don't generate enough revenue to sustain themselves.
I see.
Yeah, you do see some of that in the Eastern Panhandle with Valley Health that has made its way along Spring Mills. They've got a location
Right across
from WVU.
Yeah, WVU, yeah.
Exactly.
Yep.
They're like next door to each other.
And I would say that's great competition. Following the process, filing for it, making sure we go in there. People deserve choice. I don't think state lines are a dividing point for choice. I know that was an example that was made recently about delivering a baby at another hospital. We're a state that's losing population, so your birth rates are lower in states like West Virginia than in other states like Virginia and parts of Ohio and Pennsylvania. And you want to have a program that can deliver hundreds and thousands of babies, not dozens of babies, because the critical mass, the liability, and the expertise to keep your clinical skills strong need to have strong volume to maintain it. So hospitals struggle with those choices each and every day. What does a community need? How do we do it really, really well? And how do we maintain high quality for the patient and expertise opportunities for the clinicians?
Here's the anecdotal story of the day that's been brought to my attention by more than one person. And I have not seen hospital bills to verify this is accurate. I'm just going by what those have told me. And I'll just throw some dollar figures out. I needed to get a scan. And when I went to the hospital here, it was $1,400 for the scan. But I could go to a place in Maryland that does just scans, and I only had to pay $800. That's what I did. I saved $600 by doing that. How do you get around that, though, David? If you're a consumer of medicine.
Well, anyone can go on to our websites today. The federal government mandated to hospitals 300 shoppable services. You can go on and estimate what your out-of-pocket would cost. That was a Centers of Medicare requirement. We do that. You could go on to our CAMC, MON, any hospital website to see what it would cost for an MRI or shoppable service. Estimate with your insurance and deductible what it could be out-of-pocket so you aren't overly surprised on what the cost would be for that. And then the other economic is, David Goldberg Radiology Center LLC contracts directly with different insurance plans and then strikes a deal of what the reimbursement would be, no differently than Dr. Harvey doing the same. If you're opening up your clinic, you're negotiating. So all offices and providers may have different rates for reimbursement based on how they negotiated with the insurance company for reimbursement. It's a hard model That's why people get bills. What you get in the mail in your bill isn't always what you owe or pay. It's what the charge was. Then your providers or hospitals or ambulatory surgery centers have rates negotiated with the payers of what they're going to get reimbursed for that MRI or joint replacement or physical therapy exam.
If reimbursables were better, would that help level the playing field?
Yeah, if overall economics of healthcare were better, yes. If we had more commercial insurance, that would, of course, help the margins of all of our hospitals, goes without saying. Medicare and Medicaid are great programs, but they're limited in the reimbursement because of the way the formulas work. So, yeah, more money does always help, but it's our job not only to get more money in, but to reduce our expenses, make sure we're good stewards of the dollar, and make sure that we're providing great care with the dollars we get. More money doesn't always mean better quality. Partnering with our clinicians, partnering with insurance companies, partnering with the doctors and the patient to get people to be compliant, take their medications, get to the right site of care. Not everyone needs to go to an emergency room for primary care. They should be in a primary care home. All of the different things we try to do to coach people along the journey is to bring down the cost and improve the health and well-being of the communities we serve. Every patient, every day, every time.
We have a minute left, David. What are you expecting to hear when you get to Charleston to begin to talk with delegates and senators?
I think that, people are asking really good questions. It's a very difficult subject. When people throw out free market, healthcare's not a free market. Even if it's a CON subject aside, we're regulated by the federal government, by state rules and regulations, and our payers, the insurance companies, how we get paid, how we don't, what we have to see, how we have to see people, and reporting. So I'm hoping just to educate that we are not free market, and taking CON away, I think, is going to cause more distress to a fragile economic system that supports healthcare than where we are today. And I think we're making great progress and have to continue to make it a more healthy state and take care of our patients.
I want to thank you very much for your patience with my scheduling, bouncing you around a couple different times. I appreciate your flexibility there, and also for the information today. I think you did a pretty good job of pleading your case here.
Well, I appreciate it. Anytime I can help, I'm glad to.
Thank you, sir.
Thanks. Have a good day.
David Goldberg. Thank you, Matt Harvey, by the way, for helping to set that up.